separated from pia mater by subarachnoid space. It continues downward to envelop the spinal cord and ends by merging with the dura mater at level second vertebra. The deepest layer is pia mater. It is a connective tissue with blood vessels. It continues as filum terminal fused with periosteum coccyx. So from the outside, the outermost layer is dura mater, then followed by subdural space, then arachnoid mater, subarachnoid space, and pia mater. Now we're moving to brain regionality. During the development of embryo, the development of neural tube, it developed into prosencephalon, mesencephalon, and rhombencephalon. Prosencephalon then will later develop into telencephalon and diencephalon. Mesencephalon stays, and rhombencephalon further develop into metencephalon and myelencephalon. Telencephalon will later become cerebrum. Diencephalon will become thalamus and hypothalamus. Metencephalon will become pons and cerebellum, and myelencephalon will become medulla oblongata. So now is the cerebrum. Cerebrum is the largest division of the brain. It is divided into two hemispheres, left and right, each of which is divided into 4 lobes. So each lobe have 2 pairs. All right. Then the cerebral cortex is the outmost layer of gray matter, making up the superficial aspect of the cerebellum. So basic features of cerebrum, we can see there is a gyri. Gyri is singular and gyrus is plural. So gyri is the elevated ridge around the brain, and sulci is the small groove dividing the gyri. So this is the one is sulci, plural is sulcus. Then another one is a fissure. Fissure is a deep groove or deep sulcus, generally dividing large regions or lobes of the brain. We have a longitudinal fissure. It divides 2 cerebral hemispheres. Then transverse fissure, it separates the cerebrum from the cerebellum. And Sylvian or lateral fissure, it divides the temporal lobe from the frontal and parietal lobe. So cerebrum function of cerebral cortex is higher order functions, sensory perception and initiation and control of skeletal muscle contraction and voluntary movement. So according to the lobe, we have a frontal lobe, we have a parietal lobe, occipital lobe, and temporal lobe. Each lobe have can be divided into the motor area and sensory area and association area. Primary motor area lies at the frontal lobe. It controls skeletal muscle activity. And motor speech Broca area control muscle movement needed for speech. And this is a sensory area of cerebral cortex. There is an auditory area, olfactory area, taste area, and visual area. Next is association area. Association area is the parts of cerebral cortex that receive inputs from multiple areas. It integrates incoming sensory information form a connection between sensory and motor areas, because they are involved in organizing information that comes from various other areas of the brain. It always associate with complex function. So this is the homunculus of the brain. At the frontal lobe. Next is basal nuclei. Basal nuclei is also known as basal ganglia. It is a group of subcortical nuclei which responsible for primary motor control, such as motor learning, execute function, emotion behavior, important role in reward, and addictive behavior and habit formation. We can three part of the basal ganglia is caudate nucleus, okay, then lentiform nucleus, which is consists of globus pallidus and putamen, and the amygdaloid body. Next is limbic system. Limbic system sit at the top of the brainstem. So the function is to establish emotional state, linking the conscious intellectual functions of cerebral cortex with the unconscious and autonomic function of the brainstem. It's aiding a long-term memory storage and retrieval. Next, we go to the diencephalon. Diencephalon connects the cerebrum and midbrain. It consists of thalamus and hypothalamus. Thalamus release and redistribute impulse from most part of brain to the cerebral cortex. Whereas hypothalamus is the centers that regulate body temperature, food intake, and water balance. It controls daily cycle of activity, and it also acts as endocrine gland that controls the hormone secretion of the pituitary gland. So this is our pituitary gland, the anterior and posterior pituitary gland. Anterior pituitary gland is also called adenohypophysis. This is anterior. It's commute from the hypothalamus to the anterior pituitary to the adenohypophysis via the blood vessel called hypophyseal portal system. So hormone from hypothalamus will travel to anterior pituitary through the blood. So example, hormone from hypothalamus like GnRH, CRH, TRH, this one will promote the secretion of FSH, LH, TSH, and whereas the prolactin inhibitory hormone from hypothalamus will inhibit prolactin formation from the anterior pituitary. At the back of the anterior pituitary is the posterior pituitary. It's also known as neurohypophysis. So why it is called a neurohypophysis? It is because it is a bunch of nerve fibers which the cell bodies in hypothalamus and the axon is extending into the posterior pituitary. So hormone was produced in the hypothalamus, then was transported and stored at the nerve terminal in the posterior pituitary. Example is vasopressin, ADH, and oxytocin. So next is midbrain. Midbrain consists of nuclei and nerve fibers. This is the midbrain. Okay, the upper part is the superior colliculi, and the lower part is the inferior colliculi. The superior will control reflex movement of visual stimuli, and the inferior part control reflex movement to auditory stimuli. Then next is reticular formation. Is a network of interconnected nuclei that extend the length of brain system. Reticular activation system is to maintain muscle tone and posture, regulating the motor output in basal nuclei. Next is pons. Pons link cerebellum with midbrain, diencephalon, cerebrum, and spinal cord. Controls the pneumotactic. It is a pneumotactic and apneustic center. Next is cerebellum. Cerebellum is occupied at the posterior cranial fossa below the occipital lobe, separated by vermis. Cerebellum functions in coordinating voluntary muscular movement, posture, and balance, learning and language processing, fine-tuning, and learn movement. And the last part is the medulla oblongata. Okay, medulla oblongata is the outer aspect composed of white matter passes between brain and spinal cord. The features of medulla oblongata is the decussation from the lower part of the spinal cord, decus at the pyramids, sensory. Decussation also occur here. It is a cardiovascular center, respiratory center, and reflex center. All right. Next is the cerebral circulation. There are two main artery supply to the brain, which means the blood supply comes from the two systems. The first one is internal carotid artery, and the second one is the vertebrobasilar system. The internal carotid artery supplies the cervical, petrous, cavernous, and cerebral part of the brain. The main branch of internal carotid artery is ophthalmic artery, posterior communicating artery, and two terminal branches, anterior and middle cerebral artery. And the vertebrobasilar system start from right and left vertebral arteries join together at the pontomedullary junction to form basilar artery. Then it will later divide into two posterior and posterior part of cerebral hemisphere. So this is the famous circle of Willis. It consists of internal carotid artery, anterior communicating artery, middle cerebral artery, and basilar artery, as you can see in the diagram. This is the blood supply to the brain according to the region. So we can know if there is a stroke occur to this patient. We can correlate with the which artery affected. Next is the venous drainage. Venous system drainage can be divided into two systems, deep vein and superficial or cortical vein. Deep vein drain the internal structures. It merges from internal cerebral vein into two veins and then continues with straight sinus here. Okay, and then next is the superficial cortical vein. Superficial cortical vein consists from three parts, which is superior cerebral vein. Next is inferior cerebral vein and superficial middle cerebral vein. These three veins will further anastomotic and goes into the superior sagittal and transverse sinus. All right. So that's all from me. Brain anatomy and blood cerebral circulation. Thank you.
All right, thank you, Dr. Fathullah. I open for any question to the floor.
Okay, this is Prani here. I think it would be nice in the next time presentation kalau kita boleh relate to the contoh apa ni CT scan or the film, also ataupun slices CT scan or MRI in relation to anatomy. So this is what we call applied anatomy. To show to your friends and learn about kalau contohnya stroke ataupun just a normal setting lah, normal setting of CT scan or MRI in relation to anatomy. Okay, next time it will be better like that. Dengar agak?
Okay, thank you very much, Prof.
Okay. So sama juga kalau somebody else present on physiology ke anatomy, try to do applied anatomy, and also applied physiology. Okay.
I would like to invite Dr. Azfar and Dr. Marliana for the next presentation.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning. So me, Azfar and my colleague Marliana will continue with the next topic on approach to stroke in ED. So I believe most of us are more than expert in managing stroke in ED. So this is just a revision for us. Everyone can hear me loud, okay? So let us begin with why next. Okay, all right, sorry. So let's begin with a case scenario. So this is a 55-year-old male, premorbidly ADL independent, with background history of hypertension and DM type 2, was brought in by USM ambulance, arrived at ED at around 12 noon, with complaint of sudden onset of right-sided body weakness upon waking up from sleep. Okay, so as a physician, what do you want to do? So anybody wants to volunteer? Or may I have Dr. Amin to answer? I think it's hard for us to. Dr. Amin, can you share your opinion regarding this? What else do you want to do? Anybody else?
We have 87 participants. Should be today. Okay, please join.
Okay, ABCD, okay. What else do you want to clarify with the patient?
Hello. Onset.
Okay, all right. So it's very important for us to get further history because we want to know a collaborative history from the family members if it's occurred at home or co-workers if it happened in workplace, or the paramedics who interviewed the witness at home. So we want to know the exact time when was the last patient was found to be normal or well. Okay, so this is very important for us to subject the patient for thrombolysis, for example. So apart from that, we also want to know any other associated symptoms of stroke, like any facial symmetry, any abnormal speech, okay? any aphasia. So and also we want to rule out the stroke mimics. Okay? So any seizure prior to the symptoms, because patient may come with post-ictal neurological dysfunction, okay, post-ictal paralysis, okay, any severe headache, any co-ingestion of drugs, for example, okay, so patient may come with drug toxicity, any fever, recent trauma, and also if patient on any anticoagulants. So what is stroke? So stroke is an acute onset of focal or global neurological symptoms and signs due to vascular cause. So there is a term we call hyperacute stroke, which means that patients presented to us within the 4.5 hour from the onset. So patient is a good candidate for thrombolysis. So we do know that cerebral vascular accident is the third leading cause of mortality in Malaysia. Okay, so after IHD and pneumonia, so about 40% of stroke patient is actually aged less than 60 years old, 60. Okay, so this is quite alarming. All right, so how to classify stroke? So generally, stroke can be classified as ischemic or hemorrhagic. So majority will come with ischemic, about 80%, and the rest 20% is hemorrhagic. So hemorrhagic can be further divided into intracerebral hemorrhage, which is commonly due to hypertensive bleed, and also SAH or subarachnoid hemorrhage due to, for example, ruptured aneurysm or AVM. So in ischemic stroke, we can further divide into the underlying cause or the pathological cause. Either it is due to thrombosis. Thrombosis can be due to atherosclerosis, dissection, vasculitic syndrome, or hypercoagulable state. And cardioaortic embolism, as we all know, if patient has underlying atrial fibrillation, sustained flutter, any valvular vegetation or intracardiac clot, so this will predispose to embolism. And also systemic hypoperfusion. Systemic hypoperfusion means if patient comes with low blood flow state, for example, patient with shock, okay, arrhythmia, patient comes with hypovolemia, okay, or hypoxemia. Right, so for thrombosis, we can further divide. Either patients come with large vessel occlusion or small vessel occlusion, or known as lacuna infarct. Okay, so lacuna infarct means when there is a small non-cortical infarct caused by occlusion of single penetrating branch of large cerebral artery. Okay, so large vessel usually refers to if patient comes. Usually we know this by imaging. So if there is involvement of more than 1/3 of a vascular territory, and we can call it as a large vessel occlusion. Okay. So small vessel occlusion or lacuna infarct can be further divided based on the clinical syndrome. So there are overall 5 clinical syndromes with lacuna infarcts. The first one is the pure motor, means patient comes purely with motor weakness, okay, without sensory loss and also cortical signs. So cortical signs like aphasia, apraxia or agnosia. Next is the pure sensory, means patient only comes with a sensory loss without motor weakness or cortical signs. Next is ataxic hemiparesis. So ataxic hemiparesis means patient comes concurrently with ataxia with hemiparesis. And sensory motor means mixed both motor and sensory. Dysarthria clumsy hand syndrome is patient come with dysarthria and also weakness of and clumsy hand, mild weakness and clumsy hand of one limb. Okay, so the most common is of course pure motor lah. Right. So there are actually various pre-hospital or ED stroke screening tools, and these tools are actually varied in their sensitivity, specificity, and also the accuracy. But I want to highlight these two important scales or tools, which are the CPSS or Cincinnati Pre-Hospital Stroke Scales, as well as the recognition of stroke in ER or ROSIA. So according to a systematic review, which was published in 2019, titled Hospital Stroke Scales as Screening Tools for Early Identification of Stroke and TIA. So the authors concluded that in the field, CPSS had consistently the highest sensitivity and therefore should be preferred to other scales. And in the emergency room, ROSIA scales should be the test of choice as it was evaluated in more studies than FAST, the FAST, and showed consistently high sensitivity. So as we all know, this is the CPSS. Okay, so originally the CPSS only consists of FAS. So later on they modify and add T, which is time to call ambulance. So F stands for facial group, A is the arm drift, and S is the spatial normal spatial. If any one of these three signs is abnormal, so the probability of stroke is 72%. Okay, so this is the recognition of stroke in ER or ROSIA score. So the main aim of this score is actually to distinguish between stroke and stroke mimics. So if you can see, the first initial question is actually to exclude the stroke mimics. So this has there been any loss of consciousness or syncope? So if there is yes, we have to minus 1 point. Has there been any seizure activities? Minus 1 point. Okay. So if stroke is unlikely but not excluded if total score is less than 0, and stroke is likely if it's more than 0. Okay. So what are the important targeted history that we want to ask in a patient presenting with stroke? So of course we have to confirm the clinical diagnosis of stroke. Okay. So and determine the exact time of onset, as I mentioned before. So the last time patient was known to be well. Premorbid functional status. Usually we use MRI score or modified Rankin score. This is to evaluate the severity of the disability, and this can be used to actually compare pre and post treatment. So how patient respond to the treatment, for example, thrombolysis. Okay, and then rule out stroke mimics, and we have to ask whether the patient on any anticoagulant. Okay, so what are the common stroke mimics that we encounter? Okay, so the common cause would be the TIA, transient ischemic attack, hypoglycemia. So this is the easiest and quickest bedside investigation that we can do. Okay, to rule out hypoglycemia. Seizure. So because patient may come with post-ictal paralysis for a few hours and of course it is self-limiting. Migraine. So why migraine? Because there is actually a subset of migraine with aura. We call it hemiplegic migraine. So a patient with migraine may also come with neurological deficit. However, it is fully reversible. Okay. So syncope and also psychogenic. So less frequent causes includes any intracranial pathology like ICB, any infections like cerebral abscess, CVS is the reversible reversible cerebral vasoconstriction syndrome. Okay? So hypertensive encephalopathies or depressed, and other cause like toxic metabolic or septic encephalopathies, okay? Cerebral venous thrombosis, which is not that common. All right, so what are the clinical features of stroke? So we can divide into anterior circulation or posterior circulation. So anterior circulation can be further divided based on its vascular territory, like MCA and ACA. So commonly, patient with MCA will present with aphasia if it is a dominant hemisphere, which is left hemisphere. Patient may come with hemiparesis, hemisensory loss, monomus hemianopia, and parietal lobe dysfunction. So we know that in parietal lobe, there's a postcentral gyrus, which is our primary somatosensory cortex. So patient may come with extriogenesis. So extriogenesis is inability to recognize in an object by touch alone. So we ask the patient to close eyes, and then, for example, we put a key on the patient palm. The patient is actually unable to recognize it. Graphesthesia is inability of the patient to recognize written or drawn numbers or alphabets on the patient hands. Also by asking the patient to close eyes. Okay? The impact 2-point discrimination, sensory or visual inattention or left-right association, and acalculia, which is the ability to do simple calculations. These are the parietal lobe dysfunctions. So for anterior cerebral artery, patient usually may come with weakness of lower limb more than the upper limb. Okay, so if we have to suspect patient with posterior circulation stroke if patient come with homonymous hemianopia, cortical blindness, ataxia, dizziness or vertigo, dysarthria, diplopia, dysphagia, Horner's syndromes. Patient may also come with hemiparesis and hemisensory loss, and also any presence of cerebral signs. Okay. So posterior circulation stroke. So why do we often miss? So most of the time, we know that in patient with posterior circulation stroke, the symptoms are non-specific and maybe fluctuate. So according to research, fewer than 20% of stroke patients that present with acute vestibular syndrome have focal neurological signs. So this will make the diagnosis of posterior circulation stroke is very challenging. So the most frequent presenting symptoms include dizziness, so about 47%, unilateral limb weakness, 41%, dysarthria, 31%, headache, and nausea or vomiting. So the following features may actually increase the likelihood of causes of dizziness. The patient has history of previous stroke, history of vascular disease, increasing age, complaint of disability, abnormal gait, as well as presence of focal neurological findings. A 2009 study showed that actually the HINS exam was more sensitive than MRI within the first 48 hours to differentiate. So, like what has been mentioned by Kamarul last, it is important for us to know how to do the HINS exam. So, as what has been presented by the previous team. And performing the HINS exam plus targeted neurological exam like visual fields, cranial nerve, cerebral functions, evaluation of gait and truncal ataxia can actually help reduce the misdiagnosis. And mind you that NIHS or NIH stroke scales is not reliable in diagnosing of posterior circulation stroke. So patient with posterior circulation stroke may comes with an NIH score of 0. Okay, so we don't use NIH score. And of course, the early brain imaging is frequently non-diagnostic, even in anterior circulation stroke. Okay, what are the relevant investigations that you want to do? So of course, the bedside investigation, simple blood glucose, ECG, to rule out any arrhythmia, AF, or atrial flutter, for example. Other blood investigations, as ED is concerned, is FBC. We want to rule out any presence of presence of infections, Any evidence of thrombocytosis, polycythemia, thrombocytopenia, okay, so RFT, LFT throughout any metabolic cause of stroke, so patient with electrolyte imbalance can also come with neurological deficit, COAC, FBS, FLP, HbA1c is more on the risk factors. Infective screening, why? Because patient with infection, for example, hepatitis or syphilis, actually can predispose to thrombosis as well as vasculitis syndrome. Okay, similarly to CTD screening. So next is the non-contrast CT brain. So the main aim of doing non-contrast CT brain is actually not to diagnose acute ischemic stroke, because we know that patient presented with acute ischemic stroke can't be really visualized in CT for the first 24 to 40 hours. Mostly we cannot actually detect the impacted area. So the main aim of doing CT brain is actually to exclude other intracranial pathologies like ICD, any SOL or brain abscess. And if there's a presence of infarcted area, we want to know the extent of the infarct, because the massive or malignant infarct is also a contraindication for thrombolysis. Next is the echocardiography. Of course, this is measurement mainly in ward. Echocardiography, for example, want to look at any presence of intracardiac clot, any valvular vegetation, for example, okay, ultrasound, Doppler carotid, or any carotid stenosis.
Okay, I would like to add on about the CT brain. So actually, we had a discussion with the Neurology, I think last few months back. So we are thinking of doing now CT perfusion instead of just imaging. I mean, non-contrast CT brain, but because it's much more better in terms of detection. In fact, you can use for the what we call it wake up stroke. So tapi tak decided lagi. So I don't know when we're going to start the CT perfusion. It's not that complicated to do, but to interpret is another issues lah. So I mean for us not lah, for not. Tapi that's the thing lah. For the way forward, inshallah. Okay.
So thank you, Prof. So we know that MCA territory is a commonly affected territory in acute ischemic stroke. So we have to know how to recognize the early signs of large MCA infarct. So you can see here, this is a hyperdense artery signs. Okay, this can be actually visualized as early as 1 hour of the onset. Okay, so this indicates a large MCA infarct going on. So next is the loss of insular ribbon or loss of insular stripe. We can actually compare between both sides. So there's a loss of gray and white matter differentiation at the insular cortex area. Okay, obscuration of lentiform nucleus. So in the normal CT brain, usually the lentiform nucleus is seen to be a bit hyperdense as compared to the surrounding. So if you can see the surrounding of the lentiform nucleus is just, I mean the density is just similar. So we can say that there's a loss of a lentiform nuclei punya structure lah. Okay. So there's actually a term of posterior scolation aspect score. So we're not going to discuss about that. So it is used as part of the assessment of eligibility in receiving reperfusion therapy. An aspect score equal or less than 7 predicts worse functional outcome at 3 months, as well as high risk of symptomatic hemorrhage after thrombolysis. So we don't want to subject patient to alteplase with those with an aspect score of less than 7 or less. Okay. How to calculate the aspect score? 1 point is subtracted from 10 for any evidence of early ischemic changes of the defined region. So there, we have to assess in 2 slides. First, at the level of basal ganglia, there are actually 7 structures. So we can divide into basal ganglia structures and subganglionic nuclei. So the C represents caudate nucleus, L is the lentiform nucleus, IC is the internal capsule, I is the insula. Okay, so the subganglionic nucleus includes M1, which is at the frontal operculum. M2 is the anterior temporal lobe. M3 is posterior temporal lobe. So next is at the level of the lateral ventricles, body of lateral ventricles, just above the basal ganglia. At the level of this, at this level, we can recognize 3 structures, which are the N4, which is just above the M1 and 3 MCA area, M5 just above the M2, and M6 just above the M3. Okay. All right. So this is the suspected stroke algorithm as recommended by ACLS, AHA, American Heart Association, and American Stroke Association, 2019. And this algorithm is actually adapted by us, okay, and most of the stroke center. So when we receive a call for a stroke patient, who want to retrieve a stroke patient, of course, we have to activate the EMS, emergency response. Next is it is very important for the EMS to assess and the ABCs, okay, as usual, resuscitation and stabilization, give oxygen if to aim the SpO2 of more than 95, pre-hospital stroke assessment like our SPSS, CPSS, establish time of onset of symptoms, okay, when they will last normal, and triage to stroke center, alert hospital, and consider direct transfer to CT scan available in the hospital, and check glucose if possible. Okay, once arrive in ED, so within 10 to 15 minutes, so what we have to do is actually, of course, the usual resusc and stabilize, okay, check the glucose. So what we as EDMO have to do is just do a neurologic screening assessment. So we don't have to necessarily do the full NIHS score because this may take a bit of time. So just do a screening of the neurologic function just to establish a clinical diagnosis of stroke. Okay, and then immediately activate the stroke team and order emergency scan or MRI and obtain 12 lead ECG. Okay, so within 25 to 30 minutes, we are expecting the stroke team to come and review the patient, of course, to establish, to clarify further regarding the history. And at this time, we can they can start assess the patient using the NIHS score. All right, so in less than 45 minutes, we must be able to interpret the scan findings. If there is no hemorrhage and patient is a good thrombolytic candidate, and there's no contraindications, then we have to start the RTPA, the alteplase, within 1 hour, okay, or less. Okay? And of course, after that, begin the post RTPA stroke pathway, aggressive BP monitoring, which will be presented later. And if there is hemorrhage, of course, we have to consult the neurosurgery. All right, so this is the general management. So for BP management, I have divided into ischemic and hemorrhagic stroke. For ischemic stroke, if patient is a good thrombolytics candidate, so we must aim the BP less than 185 to over 110. So a non-thrombolytics candidate, we have to defer the antihypertensive if BP is less than 220 over 110. And according to our CPG, actually there's a bit of discrepancies. According to our CPG of hypertension 2018, they recommend that we do not lower the SBP less than 180 in the first 2 weeks in acute ischemic stroke patients unless hypertensive emergencies coexist. For example, patient come with APO, MI, or IT dissection. However, in an up-to-date, and this is what we have been practicing here, they recommend that we restart the antihypertensive BP is more than 140/90 as early as 24 to 48 hours after stroke onset, with the goal of gradually controlling hypertension within a few days to a week. So for those who have been doing neuromedical, then they know that our neurologists prefer these recommendations. The type, actually there is, for the hypertensive emergencies, there is actually no solid evidence regarding the type of the first, the first line, but they recommend that the first line is the IV labetalol or nicardipine. So the second line will be like hydralazine. Okay, so there's a consensus, but there's no solid evidence to support the usage of the drugs. All right, so next is hemorrhagic stroke. So in hemorrhagic stroke, according to our CPG, so if patient come with SBP of 150 to 220, avoid aggressive SBP lowering to less than 140. Okay, so if more than 220 of SBP, we can consider aggressive BP lowering within 6 hours towards 140. So it's not less than 140. So overall, the AHA and ASA target SBP of 140 to 160. All right, so start aspirin within 24 to 48 hours of ischemic stroke onset and avoid aspirin within 24 hours post thrombolysis. Okay. And we may consider to start dual antiplatelet therapy in high risk TIA which is defined as the ABCD2 score of 4 or more, or in a minor ischemic stroke with an IHS of less than 3 or less, who do not have a known cardiac source that requires anticoagulant. Okay, and of course, as usual, we have to control the risk factor, start stating in normal glucose of 8 to 10. So for fluid management, so we should avoid giving hypotonic fluids because it can worsen the cerebral edema. Of course, in ward, we can refer to physiotherapy or speech therapy. Okay, so I will pass to my colleague, Dr. Marliana, to continue on the presentation.
Hi, good morning. Assalamualaikum. Marliana here. I'm going to continue with the case discussion. So further history from the family members, patient was asleep at around 10:30 a.m. and then he was well at the moment before, and then he wakes up at around 11 a.m. with symptoms, the neurology symptoms. They arrived at ED around 12 p.m. On arrival, patient was alert, conscious, blood pressure of 144/90, diastolic, heart rate 80, afebrile, SpO2 100% under room air, CBS of 7.8 millimole per liter. He has right facial nerve palsy with right hemiparesis. So what do you want to do next? Does anyone want to answer the question? Amino, you are our favorite person.
Buat CT dengan ECG.
Okay. Alright, you were going to do CT and ECG for this patient. So you're going. Oh, dear. So basically, this is one of the good candidate for reperfusion therapy. So our goal of reperfusion therapy, we have immediate and long-term goal. Immediate goal is to restore blood flow to region of the brain that are ischemic but not yet infarcted. Long-term goal is to improve outcome by reducing stroke-related disability and mortality. So this is the acute ischemic stroke treatment pathway. So this is very important to know the onset of neurological symptoms. So those who presented within less than 4.5 hours is a good candidate for thrombolytic. So we have those who presented of onset less than 3 hours, onset of 3 to 4.5 hours, onset 4.5 to 6 hours. Those who presented less than 4.5 hours, we need to consider for thrombolysis if there is no contraindication. If there is any contraindication, you can opt for endovascular therapy. But in USM, I believe we don't have it here yet. Apart from that, we need to look at the blood pressure control. For thrombolytic therapy, blood pressure should be less than 185/110.
Endovascular therapy, actually for the endovascular therapy, we have the facilities actually. But the stenting, I mean the devices is very expensive compared to all the normal cardiac stenting. So it's like chicken and egg. With the radiology department, our invasive, we know we have Amin, not Amin here, I mean in radiology. Institute, what is Amin stand for radiology? Invasive lab, something like that. So they are able to do this endovascular procedure, but the thing is that the device are very expensive. So actually we are also in the process of getting the hospital to, in a way, to sponsor some patients to start with. But of course now with the limited of budget, so it's like chicken and egg lah. Kalau kita nak sponsor, then we can start with 1 or 2 patients first, or something like that. Okay, thank you.
Okay, thank you, Prof, for the clarification on endovascular. Okay, what time is brain? So the benefit of reperfusion therapy is really time dependent. So that's a one study from the NI and the S trial. So if you look at the number of patients needed to treat and NT to achieve excellent recovery MRI score of 0 to 1 within 90 days or 3 months, in the 3 subgroup, if you look at the less than 90 minutes, one of the patients have good or excellent recovery within 3 months. While from 90 minutes to 3 hours, 1 out of 9 patients will have excellent recovery within 3 months. Whereas 3 to 4.5 hours, 1 out of 14 patients will have a good recovery. So therefore, thrombolytic therapy is really time dependent. We need to assess the patient quickly and activate stroke team early. So assessment, as usual, we need to assess patient pre-atiplase therapy, during and post-atiplase therapy. So decision on atiplase therapy, first, as usual, is the onset of less than 4.5 hours. Eligibility of criteria, we show you the long list of that criteria. Then no contraindication for atiplase, good blood pressure control, CT scan finding of no hemorrhage or aspects from 8 and above. So performing neurological evaluation, the NIH stroke scale, there's a few trials. For as for practice here, we usually summarize patients, those who have a scale of 5 to 20 to less than 25. But actually, those who presented with severe scale within less than 3 hours also might also benefit from the thrombolytic therapy, as well as those who presented with mild scales score, which is less than 5, but disabling also a good candidate for thrombolytic therapy. So these are the long list of the eligibility for IV atiplase, the age of more than 18 years old. They do have trial on age 13 as well, with a good outcome. Then it's onset of less than 4.5 hours, diagnosis of ischemic stroke with neurological deficit. The neurological sign should not be clearing spontaneously, meaning that it is not a TIA or any stroke mimic. A good candidate for IV atiplase in mild but disabling stroke within 3 hours from the symptom onset. What are the mild but disabling stroke? These are list of the example. Okay, complete hemianopia, severe aphasia, visual or sensory extinction, any weakness limiting sustained effort against gravity. This is, look at the score, the scale, the question 5 or 6. And any defeat that lead to a total NIHSS score of more than 5. And the last is any remaining deficit considered potentially disabling for the patient and family. Apart from that, this is other checklist for the IV atiplase in severe stroke within 3 hours from symptom onset. Those who have no contraindication for thrombolytic therapy, a good control of blood pressure less than 155 systolic and 110 diastolic, brain CT brain normal or early ischemic changes, or we calculate the aspect score of more than 8 and above. And we need to counsel patients about the potential risk and benefit. This usage of atiplase in special group, those who have end-stage renal failure on hemodialysis with normal EPDT, we can consider for thrombolytic therapy. To those who actually on single or dual antiplatelet with normal lab parameter you can consider for thrombolytic therapy as well. So contraindication to atiplase, that's something that we need to. Okay, contraindication for atiplase is one is we unclear time of onset or unwitnessed symptom of onset. Wake up stroke who the time last known to be baseline state is more than 4.5 hours. Current CT shows intracranial hemorrhage or any history of intracranial hemorrhage. Sign and symptom that is consistent for subarachnoid hemorrhage. And then CT brain shows more than 1/3 of MCA territory. And there has a history of trauma or ischemic stroke within 3 months. Apart from that, there's a history of intracranial or spinal injury within 3 months, intra-axial intracranial neoplasm, lumbar puncture for the past 7 days, arterial puncture at non-compressible site within 21 days, any GI malignancy or recent bleed within 21 days, symptoms of IE, known or suspected to be associated with aortic arch and dissection. This is from the lab parameter, low platelet, prolonged coagulation profile, those who are on lower molecular weight heparin within 24 hours, usage of IV heparin for the past 48 hours, and prolonged APTP. On warfarin with prolonged INR 1.7, and patient who is on NOAC of less than 48 hours. So the dosage of altiplase is 0.9 milligram per kilo with maximum dose of 90 milligram. We need to actually weigh the patient. We can't simply estimate the weight of the patient. Okay. So we calculate the dose of 0.9 milligram per kilo, and we give 10% of that dose bolus. The remaining of the dose over 60 minutes.
Okay, the problem in our setting is actually we our bed cannot measure the patient's weight. So but we notice a few patients that we bit overdose. So if you are not sure, slightly lower dose is better rather than overdose. So to give the dose, previous slide, to give actually when we talk about the body drug dosage, we have like either we go by ideal body weight or total body weight. For the information that we have so far is based on the total body weight, meaning that if the patient is slightly overweight, so you have to follow that. But if the patient is small and thin, so please make sure that you really also follow that. So don't. But the problem is when I had discussion with Sania before this, some of the patient actually somehow it was overdose. So I mean you can start looking at your friend and estimating their weight rather than you suddenly you estimate the patient's stroke patient weight when they are lying down in the bed. So it's a bit tough actually. But worst come to worst, if you ask me, worst come to worst, if you cannot really calculate, you go by the ideal body weight. So you measure the patient's height. If you get the height, so you can already know roughly if you go by the BMI is around 20, so you can roughly get the weight of the patients. So you follow that if you cannot really estimate the body weight rather than you overdose the patient. Okay, thank you.
Right. Thank you, Paul. So other thing that is important is to communicate with the patient and family. We need to inform the benefit of altiplase. About 30% of patients have good outcome within 3 months, and we need to inform that there's a risk of intracranial hemorrhage of less than 7% for thrombolytic therapy. Okay, last but not least, we continue with the case. So we decided for IV atiplase for this patient. After 1 hour of completion of atiplase infusion, we noted patient become drowsy and less responsive. Blood pressure of 220, diastolic 120, pulse rate 110, temperature 36.7. SpO2 remain 100% in the room air. CBS 7.6. So what will you do to this patient? Anyone?
If can maintain GCS, can proceed with CT brain. If cannot maintain GCS, secure the airway.
Right. Thank you. So we proceed with CT brain. Okay. So we proceed with CT brain because we suspect this patient probably to have intracranial hemorrhage. So this is a management of symptomatic intracranial bleeding within 24 hours after every atiplase or during infusion of atiplase. So whenever we suspect of intracranial bleeding, we need to stop atiplase infusion, get full blood count, coagulation profile, fibrinogen level, and cross match. Proceed with CT scan, and then give patient cryo of 10 units over half an hour, 1 gram of tranexamic acid, and BP management. We need to aim BP of 140 to 160 systolic, and if confirm bleed, we need to consult the neurosurgery team. Post atiplase infusion, we monitor the blood pressure, pulse rate, and NIHSS score every 15 minutes during and every 15 minutes during and after IV atiplase infusion for 2 hours. then 30 minutes for 6 hours, then hourly for 16 hours to 24 hours. We need to monitor sign and symptom of intracranial hemorrhage as well as any adverse event including minor bleeding. Antiplatelet, we withhold the aspirin until after 24 hours, and if there is no evidence of intracranial hemorrhage from the CT scan, and we need to admit patient to the stroke unit within 3 hours after active. So what are the adverse reaction of IV antiplatelets other than hemorrhage? Patient will have nausea, vomiting, superficial bleeding from the puncture site, transient hypotension during infusion, anaphylactic reaction, perioral and lingual angioedema. I think, all right, this is our reference from the Continually Up to Date and from Prof. Kamarul and Dr. Saniha as well. Okay, that's all from me. I would like to say thank you.
I open to the floor for any question.
Video yang
I would like to invite Dr. Rahim to proceed with the next topic.
Assalamualaikum and very good morning. Jelas ke suara? Okay, so we are a bit delay in time, so we proceed with the next topic. I'll be sharing a topic of status epilepticus approach. Some of the highlights, and we know that status epilepticus, basically there is an imbalance of the neurons, the inhibitory neurons as well as the excitatory neurons, that leading to the diminish the seizure threshold. So we will go through the algorithm, some of the terminology and the definition, as well as the management. So I just bring all of you to one normal case scenario. A 20-year-old brought to ED, a history of post-traumatic epilepsy with a history of depressed skull fracture in view of MBA. So the father found him 40 minutes earlier, seizures continuously, and the paramedics give IV diazepam 10 mg on the way to the hospital. So upon arrival, patient tachycardic, tachypneic, normotensive, and saturating under high flow oxygen. And then there is copious secretion. Then we do the basic airway maneuvers as well as suction. Then we decided the patient is having a patent airway. Sugar is normal, but the diazepam no effect after we giving repeatedly again and again. Okay, so coming into the definition of the status epilepticus, so we know that there is evolving of the definition of the status over the years. So this is the latest one, whereby 5 minutes or more continuous clinical and or electrographic seizure activity, or recurrent seizures activity without recovery, without return to the baseline in between the seizures. So there is another entity of under definition of the status epilepticus, refractory status epilepticus, whereby the patient do not respond to our standard treatment of the status, where we have been given the adequate doses of the initial benzodiazepine, followed by the second line of treatment, which is non-benzodiazepine anti-epileptic drug. So just we have to bear in mind, 40% of the status epilepticus will be come into this category. So another sub definition called super refractory or malignant status epilepticus, where there is a recurrent seizures in spite of multiple anticonvulsants as well as the anesthetic medication beyond the 24 hours. Okay, coming into the classification of status epilepticus, many authors in general classified according to where the seizure arise, where there is origin, localized region, where we call it partial onset, or there is involving of the both hemispheres, where it is a generalized onset. Another type of classification we can classify as convulsive status epilepticus, where we can see there is a jerky movement of the limbs, and non-convulsive status epilepticus, where this we only can detect by means of the EEG. So I believe some of the ED center do have the EEG in emergency setting. So sometimes this type of patient in this category, there is minimal subtle motor signs like there is trismus, there is twitching, or there is blinking of the eyes, and so on. So, but in this convulsive status epilepticus, only we can categorize this one, as well as unless the patient is generalized tonic-clonic, there is impaired motor impairment, and there is a focal neurological deficit. Okay. So when we talk about the etiology of status, there is a long list of the causes why the patient develops status. But in this journal, they divide into 4 main categories. Infection about 50%, and metabolic causes about 40%. Stroke, post-infarct seizure is 12%, and if the patient defaulted the anti-epileptic drug or suboptimal treatment, about 8%. So what our aim of treatment for this kind of patient? Number one, we should terminate the status abruptly, because the longer the seizure occur, the higher the chance that the seizure won't respond to anti-epileptic drug, and the higher chance of the permanent neuronal injury will occur. Second one is we want to prevent another episode of the seizure, as well as we have to treat the underlying cause. Don't forget, we have to anticipate the complication that will arise from the status epilepticus itself, such as hyperthermia. So we have to cool the patient, hypotension, acidosis because of accumulation of the lactate, and hyperkalemia rhabdomyolysis, as well as the aspiration. So basic approach to this patient, the status patient, we start from the ABCD, airway, breathing, circulation, and disability. So we should know that airway is our priority. Then we should see the pattern of the breathing of the patient, and we see the hemodynamic of the patient, and the disability screening of the neurological examination to localize whether this is intracranial pathology or other causes. And don't ever forget our glucose. It is embarrassed if we treat the patient but we do not do the glucose level. Sometimes we do forget, the whole team forget to do the glucose level. Put the patient in left lateral position, give the non-rebreather oxygen, and get the IV access. This point also, do not delay to give the initial anti-epileptic drug, the benzodiazepine. Nowadays we have multiple route of administration. Sometimes some of the patient is a very difficult line, so we can give either the rectal diazepam or we can give the IV midazolam, or now we have the buccal midazolam, depends on the availability in the center. Continuous vital signs monitoring, do some bedside investigation for blood count and electrolytes, and from case to case basis, maybe the CT brain is indicated. And as I said in the previous slide, ideally the continuous EEG monitoring is better in terms of diagnosing the status, as well as in terms of the monitoring the our treatment given. Toxicology screening, if the history is indicated, the serum anti-epileptic drug is good to do, because we want to see whether this patient is subtherapeutic or not, and other investigation that can help into our management. Okay. This table from the Neuro Critical Care Society, you can see time-based treatment. Excuse for the a bit busy slide. You can see immediate means the less than 10 minutes of treatment of arrival into the emergency department. So in view of the positioning of the head, oxygen, the hemodynamics of the patient, if we know the patient is hypotensive, want to maintain the cerebral perfusion pressure, so we should give start the NORAD, the fluid resuscitation, neurological examination, and then other investigation that indicated. Okay, many randomized control trial say that the benzodiazepine would be our initial anti-epileptic drug. So whether diazepam, lorazepam, or midazolam. So some authors say this is superior than the other one, but basically we should know the dose and don't give underdose, because one of the cause the seizure will recur because we do not optimize the dose of the anti-epileptic drug. Okay, so depends on availability. So we do have rectal diazepam, we do have IM midazolam. If IV access we got already from the pre-hospital care, so we can give IV medication. So just be familiar with whatever drugs that you give. We know that benzodiazepine can cause cardiorespiratory depression, so we should monitor the pattern of the breathing, oxygen, vital signs, and then not overdose the patient, because patient can drowsy, sedated, and cannot able to maintain the airway. Okay. So another table basically is the same, but we add on another type of medication. So we know the initial treatment is our benzodiazepine. The second one, we want to load normally whether from the IV phenytoin, Epilim, or Keppra for the second line. And then the next one, we know that if the patient still refractory, so we should consider early intubation, and then we should start the anesthetic medication such as a propofol infusion or ketamine infusion. There is in view of the ketamine medication, there is the author said ketamine is pro-convulsant as well as the anti-convulsant. So if we have another option, is better we start others lah. So number one, be familiar of the medication, anticipate the side effect of the medication, and optimize the dose of the anti-epileptic drug. Ketamine should be our last result lah. So this from Tentinelli page 1177, another algorithm. So active seizure 0 to 5 minutes. So basically the supportive treatment, IV access, monitors, airway, oxygen, and glucose, and patient protectant. The next one, we know that this patient is in status. So apart from the initial benzodiazepine, we have to add on the phenytoin or Keppra, and back of in our mind, consider intubation. Okay, If the patient is another level, which is a refractory status epilepticus, patient still seizures, so we should add on another type of anti-epileptic drug, and this patient is a good candidate for intubation to protect the airway, then as well as to give sedation to the patient. And then ideally we should continuous EEG monitoring. So from the under level of refractory status epilepticus, you can see the first box is midazolam, then they load first, then followed by infusion, either or propofol infusion, or the ketamine infusion, or the phenobarbital. So this proposed algorithm by American Epilepsy Society more or less is the same. So from the time base, the initial one, stabilize the patient, monitoring, IV access, blood taking, get the proper history. The next one, we see whether the patient still continues seizures or not. Then we load the patient with another type of anti-epileptic drug. The next one, if patient is refractory, consider intubation, and then start the anesthetic infusion of anti-epileptic drug, and then followed by try to search the cause of the seizure. So this another our own guideline from USM in 2016 by our own Prof. Kamarul. You can see basically it's the same. So IV diazepam first, then still seizures. So we should add on another dose, and we load with phenytoin under cardiac monitor. Phenytoin, as I mentioned just now, be familiar with the drugs. There is one time we encounter when we load the phenytoin to the status patient. One of the referral doctor come and see and ask us where is the cardiac monitor, where is the baseline ECG. So it is so embarrassed. Not happen in USM, it's some other place lah, but this truly happened. Familiar with phenytoin can cause arrhythmia, phenytoin can cause hypotension. So be familiar with your drugs. Okay. Okay, so just one slide regarding eclampsia. So in childbearing woman, don't forget to ask for the LMP, because eclampsia we should treat with the IV magnesium. And then this is a red alert. So it is another entity of the seizures. So don't miss it. Don't miss it. Okay, these are my reference. With that, I thank you. Thank you for your attention. Thank you so much.
I open for any question regarding the status epilepticus topic.
Yeah.
All right. So I would like to invite Dr. CK proceed with the topic drugs.
Hello. Morning, everyone. Can you all hear me? All right. So I'll be presenting on anti-epileptic drugs, so you can call it anti-seizure drugs in this case. So before that, I'd like to introduce myself. My name is GK. I'm here to sell drugs information. I'm not drug from drug rep, and I'm not a pharmacist, but I'll try my best to deliver the information best I can before you all like it. My topic is a bit dry and a bit. So just a bit of a recap of the introduction. For the seizure, is we know that is an episode of abnormal neurological function caused by inappropriate electrical discharge of the brain neurons. And epilepsy is a clinical condition which an individual subject is to recurrent seizures. So when the status epilepticus is seizure activity is more than 5 minutes or 2 or more seizures without regaining consciousness between seizures. And the refractory status epilepticus is a persistent seizure activity despite the IV administration of adequate amounts of 2 antiepileptic agents. Okay, so we just go before we proceed to understand like what are the drugs that we need to know. We just need to understand some basic neurophysiology. Um, as we know, they always have a balance in life where there's a major excitatory neurotransmitter like the glutamate, acetylcholine, and also the major inhibitory neurotransmitter like the GABA and glycine, and also the homeostasis of the glutaminergic excitatory, and also the gamma activity balance. So there's always have a balance in life. So what happened like when you have like too much excitation, for example, like the ionic inward of the sodium channel, the calcium channel, and also the glutamate, or too little inhibition, like the ionic inward channel of the chloride channel and also the GABA, you have seizure. Okay, so the seizure is when the clinical attack setting of inappropriately excitatory activity. So when you have too much excitation, too little inhibition. So we go to the pharmacology part of this. So I like to present my anti-epileptic drugs in a way that we go by differentiating the drug according to the mechanism of action. So first of all, like for the main, there are quite a lot of like anti-epileptic or anti-seizure drugs that we know, but there are 3 main mechanism of actions. Some they overlap, some they have 2 mechanism of action, but mainly the first is the inhibition of the sodium channel. Second is the inhibition of the calcium channels, and third one is the enhancement of GABA actions, which is the chloride channel. So you can see that even like the glutamate, but glutamate falls under sodium. It needs a sodium channel to go in, then only will release at the glutamate receptor channel. So we go through the first mechanism of agents. For example, the drugs like carbamazepine, lamotrigine, valproate, phenytoin, and topiramate. So the drugs bind professionally to inactivate the closed sodium channel, stabilizing them in the inactivated state and preventing them from returning to the resting closed state. So this is ability to prevent the high frequency of repetitive activity. The second mechanism of action is the inhibition of the calcium channel. The ectosamide, valproate, lamotrigine, they inhibit the T-type calcium channel in the thalamic neuron, which involve the auxiliary neural activity, especially in the absence seizure. And finally, the third mechanism is enhancement of the GABA action. The first one, like the benzodiazepine, it increases the central inhibition by enhancing of the action of the GABA A receptor. So the vibarotrin is an irreversible inhibitor of GABA transaminase, which increases the GABA levels. And also the tiagabine, which inhibit the reuptake of GABA. So of all my slides, I think these are the most of the important slides that we need to know the mechanism of action for anti-epileptic drugs. So I hope you all can, if you cannot remember anything from myself, you can remember these three important mechanisms of action of the drugs. Okay, so to summarize, you can see that first we mentioned that the sodium channel here. So you can see the sodium channel we block here, the carbamazepine, valproate, phenytoin, and then to prevent the release of the glutamate receptor here. And also the second one is the calcium channel, like the etoxaparin and the valproate. You block the T-type calcium channel here. And eventually the enhancement of the GABA, the chloride channel here. So these are the just a summary diagram to show the three main mechanism actions of the anti-epileptic drugs. Okay. So what are the common anti-epileptic drugs? Because as we know, we have a lot of anti-seizures and anti-epileptic drugs. Like even if you want to know a little bit of the history, the first anti-epileptic drug like discovered was I think it was a potassium bromide. It was discovered in the 19th century by Charles Lecoq. At that time, he was trying to treat some hysterical ladies that came and even give to them and somehow like calm them down. So you can see that it was developed back. I mean, it was like discovered back in 19th century, and then the phenobarbital, the phenytoin, even in the about for 50 years already. And as you can, there's newer drugs and all. Even like now, there's like a discussion between the use of the cannabis oil for the anti-epileptic drugs as well. So first, because it depends on the hospital settings, and a different hospital will have a different drugs. So these are the common drugs that as we uh, uh, like more exposed to. Like for example, we have the midazolam, so known as the domicum, which is the short acting, lorazepam, the active intermediate acting, also the diazepam, the long acting. So the dosage here, I won't go through like one by one. I will just highlight some of the key things. We know that it's always safe between, like for benzodiazepine, 0.1 to 0.2 is always safe, except for the lorazepam, just keep 0.1 mg, maximum is about 4 mg. And depends, you have the buccal midazolam, we have the buccal midazolam, some center do have it, and also the rectal diazepam, especially during the pre-hospital care. As for the side effects, we have CNS, depression, drowsiness, ataxia, headache, respiratory distress. So diazepam binds to PVC plastic, so we don't give diazepam through like plastic. We don't give infusion because it will stick to the plastic, so it won't deliver. It's not recommended to do that. So and then the diazepam is not removed during HD. Of course, you have the tolerance and dependence for the certain patient that been exposed to benzodiazepine like previously. And in pregnancy, it does, like some studies shows that it does cross the human placenta and cause some tragic effect. Just have to be careful. If we really have no choice, then we have to give that. But the risk definitely is there. Sometimes we have to explain to the patient after that, after we have given. But avoid. The best is to avoid. And phenytoin and phospheniton. Uh, Phospheniton is just a product of the phenytoin. It's more water soluble. Can be given IM, but it's less predictable and longer onset time. The dose is the same, 20 mg per kilo. Just to keep in mind that for phenytoin, we have to keep the slow infusion, 50 mg per minute, not to give too fast. Patient will go hypotensive, and then a patient eventually develop arrhythmia after that. So in pediatric, same dose, 20 mg per kilo as well. Just be careful not to give too fast, even in the pediatric and among the elderly as well. So the side effect, as we know, the phenytoin is arrhythmia, heart block, and then you have your VF. So especially those patients that have like those came with heart block, just have to be careful when we give any arrhythmia. We have to really be careful when we give phenytoin to them because it exhibit class 1 anti-arrhythmic properties. and then hypotension, hepatotoxicity, and then the longer terms you have like the gingival hyperplasia and all. So just that when we give IM for the phosphonatoin, you have like injection site reaction, and also sometimes local tissue necrosis. Even IV lines also. Sometimes we have to just be careful. And it does cross a placenta. Have to be careful in a pregnant lady. Okay. For the next drug that we commonly use, Keppra, can give IV and IM. The dose is about ranging from 20 to 60 mg. Some recommend about 40 mg per kilo. The max dose is 4,500 mg per dose. So the side effect include hypersensitivity, CNS depression. We have like all this impaired coordination. You know, so just be careful when you use it among ESRF patient with some renal impairment. Okay. Next drug will be the valproic. This drug is some they have quite good available, like do provide it, like my center they have like the IV, can get it very easily, but you must remember, must give it at the rate of 10 mg per kilo per minute as well. So the side effects uh, including hepatotoxicity, pancreatitis, thrombocytopenia, coagulopathy, and hair loss. So in a pregnancy, it also cause a major congenital malformation. So just be careful giving pregnancy patient. And Firavito, also known as like in the group class barbiturates, can give IV 15 mg per kilo. Repeat after 10 minutes. The side effects can cause bradycardia, hypertension, respiratory depression if when you give too fast, and also CNS depression, and also allergies. Pregnancy to use in life-threatening emergency where there is no drugs available. Try to avoid if possible, especially in the first trimester. And the next one, next of drugs is like usually there is like the third line of drug for the refractory status epilepticus, like for example the propofol, dose is about 1 to 2 mg per kilo. Side effects is hypotension, respiratory depression, burning sensation, injection, and of course the hypersensitivities or allergies. So it's quite safe, although it's not. I mean, its pregnancy category is category B, so it can be used like in a certain, like when a pregnant lady. And finally is ketamine, also used in mostly in a refractory status epilepticus. Dose is about 1 to 2 mg. Side effect includes the hypersalivation, increased ICP, bradycardia, cardiac arrhythmia, hypertension, and apnea. Of course, the respiratory depression. So these are references. I hope you all can get to deliver. I don't go too fast. There's any question, can ask me onto the floor. Dev, from the chat, diazepam can cause low. It does can benzodiazepine can cause a low BP. Yes. Anything else? Question? If there's no question, that I end my slide. Thank you.
Okay, thank you, Dr. TK, for the nice presentation. We come to the last presentation. Will be discussed by Dr. Hatif. So, without further ado, we welcome Dr. Hatif to present the final topic before the games. Thank you.
Ya, dah tutup ni. Okay. So today, I know that it's going to be lunchtime. So tak apa kalau nak tak apa sambil makan sambil. Okay, so our next to Localization in Neurology. Okay, so for I want to outline issue. Of us felt very challenging, very daunting regarding CNS examination and also CNS disease lah. So to know, so that's why we have this topic to localize where is the lesion. So we can either approach this particular problem through anatomic presentation of the tracts and also the lobes or the areas inside our brain or brainstem. And then we also need to know what is the physiologic or etiologic causes of that particular lesion. Okay, and then we summarize everything and we localize the lesion to that specific part of the nervous system. Okay. So the best way to localize is not from CT scan. It's actually from your history and physical examination. So one tip I got from my neurosurgical colleague is you arrange your history based on your physical examination. So actually, when you ask patient accordingly, you can realize that your physical examination is actually confirmatory test for your history. So when you do a CNS examination, when you get a patient, then you will start with higher mental function, you will start with mental status, and then you proceed to cerebellum uh, lesion or brainstem, and then you go down to cranial nerve, you go down to motor, you go down to spinal cord, you go down until muscle. So all the history you will not miss if you go through all the anatomical lesion from upper motor neuron to lower motor neuron accordingly. So your physical examination also follow that particular pattern. Okay, so I'm sure that you all have already heard about this particular topic, upper motor neuron versus lower motor neuron. We have been bombarded with this particular characteristic regarding upper motor neuron and lower motor neuron. But bear in mind, this will present in a patient who have a motor deficit. If the patient doesn't have a motor deficit, it's gonna be a bit difficult for you to know whether this patient have a lower motor neuron or upper motor neuron. Okay. Okay. So our CNS system is actually a very specific system. So it started with our brain, from cortex, subcortex, brainstem, with addition from tract, cerebellum, spinal cord, and then it goes to lower motor neuron, which is anterior horn cell, nerve root plexus, peripheral nerve, neuromuscular junction, and last but not least is the muscle. So when you want to localize, you need to have these particular anatomical landmarks inside your mind. So you have to draw brain, spinal cord, go down to anterior horn cell and everything. So this really needs you to have a good grasp of your neurological anatomy knowledge lah. But sometimes we are not neurosurgery or neuromedical specialists. So we have a cheat sheet, not the sheet lah, but the cheat, tipu punya rajah, gambar rajah. Okay. So this is our cheat sheet. Okay, this is the summary or the important landmarks or important symptoms or signs that correlates with the levels of the CNS lesion. Okay, so for example, the easiest one we know spinal cord is a upper motor neuron, and the red lesion, the red words there is sensory level. So it follows a sensory level, such as the dermatome, or they have a certain sensory level that you can identify. So let's say we go to brainstem, upper motor neuron, and in brainstem you have cranial nerve involved. Cranial nerve involved, usually ipsilateral. So when you go through this particular diagram, you can actually point out where is the lesion according to the typical presentation of the sign and symptoms of the site. Okay. Okay, for this particular diagram, you can go through it on your own. I'll proceed with case discussion so that we won't waste so much time on this.
Okay, Assalamualaikum. Actually, if you notice at the top left over there, there is a logo of emergency neurology masterclass. That one is my logo. I designed it. Not me lah. I mean, my brother designed it. Of course, based from my input. We are going to start. I'm going to start this so-called like emergency neurology class for basically a first liner lah. So the final year we will start first. Maybe around August. Maybe any final year leader can come and we can fix one day. So we can do this localization, and the table just now also was from me also. Tapi that one is I kena revise sikit lagi. A few things that I need to add. So I will share with you all time to time. Inshallah, we will try to improve how to localize lesions, especially when patients come to ED, because this is the first step. If you cannot localize the lesions, then very difficult. Because first thing is we know in Malaysia there are less numbers of neurologists in the public services compared to the private services. So most of the neurologists are in the private services throughout Malaysia. And each state usually one neurologist, like Seremban, Negeri Sembilan, Melaka. So you will have difficulty. So your first line will be from either medical or orthopedic. So you will face difficulties to convince them whenever you make your diagnosis, especially when their ego is very high. So it's difficult to talk with them. So it's good if we were able to do the localizations. So insyaAllah by August, I think sebenarnya tak siap bagi slide dekat in the process. So I bagi sikit baru dekat Hatif. So these are my slide actually. So insyaAllah by August tu insyaAllah we'll be ready. Then we will start with the final year first. Okay, thank you.
Okay. Thank you, Prof. Kamarul. So we continue. Okay, this just want to show you that in our cortex, there are many lobes and many associated areas that have a specific functions. Okay. Okay, just bear in mind that in a previous CME, we already discussed about spinal cord lesions. So in this CME, I won't touch regarding spinal cord lesions. So you can just focus on other parts of the brain and also the nerve. Okay. Okay, this is an interactive session. If you want to ask questions or you want to answer questions, you can just raise up your hand and have a chat. Okay. So first, we do some warm up. Okay. Okay, warm up. Okay, so this is the very simple presentation which you won't get in most of your patients Okay, so this is the exam-based punya demonstration. Okay, so first patient, reduce pain, right big then, reduce vibration sense in the left fifth finger. Okay, I just give you about 10 seconds, then I'm gonna discuss these things. Okay, so for for sensation deficit, what I find helpful is you have to know which track is involved. Okay, we got only basic two track, the posterior track or the anterior track. Okay, which is dorsal column or the spinal thalamic. So this pain, the first symptom is actually from the spinal thalamic. And then the vibration sense is actually from the posterior track. So you have a diagram of the CNS tract. This is the upper motor neuron part. You can actually pinpoint where is the location. Okay, I'm sure you have already the answer. So I just give you the answer. Okay. So the purple track is actually uh, the spinal thalamic tract. Okay, it goes up a few level, then it decassedes. The yellow track is actually the dorsal column. Okay, it goes up and then decassedes at the medulla. So what I want to highlight in this slide is sometimes in localization you won't get only one particular area. Sometimes you can have a guess of one or two areas. Okay, so like this one, it may be from the upper cervical medulla. For the next one, impact abduction right, weakness, left ankle dorsiflexion. Okay, okay, right. So this is the lesion. So as you can see, sometimes we can localize the lesion at a one particular anatomical site. Okay, for this one, the cranial nerve actually help us to point out to a specific location. So throughout your examination, sometimes we left the cranial nerve examination to our neurosurgery or neurological colleague because it is a hassle. Our patient is not sometimes fully responsive. Our patient sometimes not cooperative. So we have other patients that is more life threatening for us to save. But when you do a simple in term, right? Okay. Okay, last one. Okay, this is the answer. Weakness. Weakness sometimes it's not necessarily comes from the spinal cord or the peripheral nerve system. It sometimes can go up to the cortical level, and usually it involves the tract from cortical down to the brainstem because you have all the tract inside there, and it usually is uh, uh, counter apa, the it's not EMC lateral lah, it's contralateral. Okay, so this you see that the spinal cord ada to do physical examination to elicit more symptoms or signs for this patient. Okay, now maybe some of you felt this is a bit too fast, confused. Some of you and getting okay, just more difficult. Okay, so now we have 72 years old woman. The symptom is sudden weakness, right lower face, arm and leg. So the whole right side is weak. You do physical examination, memang power weak. The whole right side. And then there is a breeze reflex, right side. Babinski outgoing, right side. So these two information, the reflex and the Babinski, shows that it is upper motor neuron. Okay. So you know that this is from spinal cord up to the cortical level. And then you add on another physical examination. You are so good, you do the sensation for this patient. So the sensation is intact bilaterally. So where do you think this patient have the lesion?
Internal capsule.
Okay, the whole right side, upper motor neuron. Could it be, you can start from the up lah, cortical ke, from subcortical ke. If you feel that you are not sure, cortical, subcortical, you just try to guess. This lesion can be in the left side or right side. You start from there. You start from a very general coarse localization. Okay, so this maybe right face, arm, leg, weakness. So corticospinal dikasih, then this is should be on the left side of the lesion lah. Okay, if on the left side of the lesion, could it be why the face is involved on the same side of the arm and leg? Shouldn't it be the cranial nerve usually in ipsilateral kan? Jarang-jarang ada cranial nerve yang dikasih.
Internal capsule.
Adalah cranial dikasih, tapi itu later. But for now, cranial nerve over the face, most of the time will have no decussation. Okay, so can it be from cortical level? Okay, if it involve cortical level, dia ada weakness right side of the face, arm and leg, but sensation is normal. If you see our cortex, the number 3 is our motor part and the next is number 9. Number 9 tu post-central gyrus is our sensation. If the lesion involve up to face lah, arm lah, leg lah, so it must have a very big lesion to become such symptoms lah. So if it is big, it will kacau the sensation juga. But now sensation is normal. So unlikely lah dekat cortex. So whereas you go down maybe some lesion in the cortical. So this patient actually have some lesion in the internal capsule, particularly over the posterior internal capsule. Posterior internal capsule, you have corticonuclear and also corticospinal tract. Okay, corticonuclear is the facial nerve tract up to the cortex, face. Corticospinal is from cortex down to our limbs. Okay, so why sensation is spared? Because sensation is supplied mostly from the superior thalamic radiation, the blue color. Okay, so this blue color, if you look at the diagram below, it have a different vascular supply. So the posterior limb of the anterior capsule comes from middle cerebral artery, but the blue one, superior thalamic, is actually from the anterior choroidal artery. So this particular lacuna stroke, sometimes you get a pure motor stroke. So this is why you have pure motor, not sensory motor stroke. Okay. Okay, so we move on to the next one. Same patient, another patient came in, 72 years old juga. And then you do all this examination, you noted, sensation pula reduce. Sensation reduce, and then patient have some language problem, have difficulty to talk, but she can understand. So you talk to the patient, but patient cannot reply to you. And then you see the eyes deviated to the left side. You have a gaze preference. Okay. So this one, just now we discussed about subcortical. So memang unlikely subcortical. We already talked about motor involving sensation, maybe cortical lesion. So I just talk a little bit about aphasia. Okay, so aphasia you have all this lah. So you need to know patient fluent or not, patient comprehend or not, patient can repeat or not. Then you can tell what is the type of patient's aphasia. So for this patient, it's a Broca aphasia lah. So Broca aphasia is over the frontal lobe. Okay, in the frontal lobe, supplied by middle cerebral artery, the superior branch. Okay, superior branch usually most commonly akan affected in the ischemic stroke lah, especially cardioembolic. So we also have area for ice, contraversion of ice. This one for gaze preference. So if the superior branch of medial cerebral artery is blocked, then we have these symptoms: broadcast aphasia, gaze preference, sensation involved, and also the whole right side will be weak. Okay. Okay, so in this patient, why not tumor? Why not abscess? Why not other disease lah? Because in CNS, in central nervous system, we can classify etiology based on the duration. We have a subacute, acute, or chronic, or sometimes they even pecah lagi acute on chronic. So subacute usually is a vascular. Acute sometimes can be vascular if patient came late. Sometimes can be demyelinating disease. Chronic is a chronic problem lah. Chronic like tumor or any congenital malformation, macam tu. Okay. So this is a differentiation between cortical lesion and subcortical lesion. What I want to highlight to you is in cortical lesion, most of the higher mental function is involved. So in subcortical, most of the basic perception like sensory motor is involved. So when people present to you or you read in a case report in a journal, patient have aculalia, agraphia, blah 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 tu, most of the time is from cortical lesion. It can be either lobe lah, mana-mana lobe pun, parietal ke, frontal ke, temporal ke. So all this complex perception, perception yang dah di computated by our brain. So the basic perceptions can affected by subcortical. Okay. So in stroke we have syndromes. So for each arteries, each blood supply, they have a syndrome. So if certain artery block, it will produce a certain symptoms lah, and it depends on how large the area, and you can see all the symptoms lah. Okay, this one you can explore on your own. I just give this slide for you to revise later lah. Okay. Okay, so next we go to a new patient, 45 years old, gradual weakness. Just now sudden onset, now gradual weakness, right face, left arm and leg. So it's a contra lesion. Okay. So on examination, you have left arm and leg, right face, loss of corneal reflex, loss of forehead wrinkle, loss of nasolabial fold. Okay, this right face weakness is actually showing you a lower motor neuron. If you didn't focus on your examination on the arm and leg, if patient come to green zone on a wheelchair, you don't check the arm and leg, you just focus on the facial asymmetry of the patient's face, then you might diagnose this patient as Bell's palsy. And then you maybe discharge the patient for TCA later but it turns out this patient has some more sinister lesion. Okay, then you proceed because you are so good, you proceed with the reflex. Reflex show upper motor neuron. So unlikely Bell's palsy lah. And then you see the eye. The eye able to look to the right side and have diplopia when look to the picture there. Is a sixth nerve. So sixth nerve palsy with upper motor neuron lesion and also some form of weakness. Okay, tak apa. So you don't know, you unsure the localization. You just know maybe this patient because the weakness on the left arm, so maybe the lesion on the right side, right face, so ipsilateral facial nerve palsy, so right on the right side lesion. Okay, you just know that right side lesion, upper motor neuron. Okay, so you do a CT brain. Do you see anything from the CT brain? The answer is no. No, the answer is yes. But you have to be very, 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 very observant. Okay, on the right pontine, there is some hypodensity. Okay, if you do a CT brain without localization, you won't look at the pons because usually posterior fossa structure in a CT scan is a very will produce a very bad image. So you almost cannot see all the hypodense lesion or the early changes of a stroke. So when you do a localization, you know this patient have upper motor neuron with cranial nerve palsy. So cranial nerve 6. Cranial 6 is in the pons. The nucleus is in the pons. So you look at the pons. Okay. So when you do MRI later patient in the ward, you can see there is a changes. There's pontine stroke. Okay. So why this patient have lower motor neuron facial nerve? Because the ischemia might not be at the nucleus. So this is where you have to differentiate supranuclear palsy or infranuclear palsy. Okay, supranuclear palsy is upper motor neuron lesions. Infranuclear is the lower motor neuron. So if the ischemia affecting the nerve post nucleus, after the nucleus came out, then is a lower motor neuron. So that's why our patient have a total loss of facial nerve function over the right side. Okay, and it involve the abducens nerve because it is close together with the facial nerve lah. So that's why if you have one lesion of the cranial nerve, you need to check other cranial nerve also because usually they are close together. Okay. In examination, sometimes these are the popular questions, these are the popular cases lah. The eponym of a CNS lesion. So the best way to counter this, to settle this problem is you know cranial nerve, which cranial nerve at what level. So midbrain usually 3 and 4, pons 5, 7, 6, and then kalau medulla 11, 12, 9, 10. Okay, so the eponym might not be so important, but the localization of the lesion is more important lah. Okay, 76 years old male, got fever, headache 1 week. Okay, so this one might not be a vascular things. Fever shows some kind of infection lah. And then you got a left eye ptosis, mydriasis, failed abduction, and then sensation reduced upper and mid face. Okay, so you know that this involve third nerve and also sixth nerve on the left side, and some sensation reduced. So cranial nerve 5, trigeminal. Okay, so 3, 6, 5. But the trigeminal only upper and mid face only. So you have to know where is the lesion that all these cranial nerve bundle together. Agak-agak kat mana? Okay, so this is the course of third oculomotor nerve, third nerve. So post oculomotor nucleus, it will go travel through the internal carotid, the supraorbital fissure, and go to our extraocular muscle. Okay, other cranial nerve also will have this kind of pathway. So it's good to know it generally where is the nerve bundled together, so you know where is the location lah. So for this patient, the location is at the cavernous sinus. So the abducens nerve, the trochlea, the oculomotor all bundled together. If you see cranial nerve punya coronal section, you can see that the V1, V2 of the trigeminal branch also go through the cavernous sinus on the lateral part. Why not superior orbital fissure? Because superior orbital fissure lesion there usually is very small area. So if it's a small area and it also have closely adjacent to the optic nerve. So when involves superior orbital fissure, it will surely involve optic nerve because there is a very small space inside our orbits. Okay, so same patient, but you noted that this patient have a cranial nerve 3 palsy, also have hemiplegia on the left side and reduced consciousness. So you cannot do much on this patient. You just based on history and also simple physical examination. Based on this, where is the lesion? So it of because involve cranial nerve 3, so must be in the midbrain lah. So we just don't know what is the etiology. So you do MRI or CT scan, noted there is a tumor over the temporal part. So this patient is actually having ankle herniation. So ankle herniation which push the oculomotor nerve. Okay. So the ankle push the oculomotor nerve, causing oculomotor nerve palsy, and sometimes it will push the midbrain, the corticospinal tract, also will cause hemiparesis. And if patient it doesn't seek treatment, if the ankle herniation progress, it also will occlude the posterior cerebral artery, which supply the occipital lobe and cause visual problem. So this is not limited to tumor, abscess, or any other lesion in the brain. It also sometimes in trauma, you need to look for oculomotor nerve as well, because you will not, you will maybe patient already herniate, have ankle herniation, but you didn't realize. So you have to check for oculomotor nerve. Okay. So this patient, 20 years old male, already using wheelchair since primary school due to some neurological problem, and then noted unresponsive, got chesty cough and fever. When the patient came, brought by ambulance, already obtunded, you just see there's a symmetrical muscle atrophy. You do some reflex, areflexia. But because this houseman, dia tak buat full physical examination. So you are not sure, where is the localization? You just know muscle atrophy only. Okay. So I just want to give you tips. In unresponsive patient, you have to do CNS examination. Even patient are responsive to you, but not to the physical examination. So you have to do mental status. GCS is trauma. You can use a 4 score. 4 score is to replace GCS. But GCS dia ada verbal component. So sometimes we cannot ask the patient for verbal. So V always 1 je. So in 4 score, they replace with other things like respiration. Dia punya, adalah nanti I tunjuk dia punya gambar. So cranial nerve. Cranial nerve, we have a limited cranial nerve examination. But you can see that based on this cranial nerve, it is actually give you location like 3, 2, maybe upper midbrain or cortex. 5, 7 is in the pons. 9, 10 is in the upper medulla. Okay, so you just do all this, and then the rest is just posturing, tone, reflex, Babinski, movement to pain. Is to look for motor, reflex, and also sensation. And cerebellar sign, you can always see from the sign lah, pendular knee jerk or nystagmus. Okay. Okay, this is the 4 score. So you eye and motor is the same. It's just you have brainstem reflex and respiration. They add on lah, ganti verbal. Okay. Last ke? Okay, so 32 years old, weakness bilateral lower limb, 5 days, unable to walk. So bilateral lower limb, quadriplegia. Paraplegia. And then you do the cranial nerve, noted there's a double vision and also numbness over the toes and fingers. And then you do the examination, power 0 on the lower limb, upper limb just 3/5. So there's some power deficit over the upper limb also. Areflexia, tone hypotonia, Babinski downgoing. So all this shows you there is a lower motor neuron lesion. Okay, so lower motor neuron lesion. So you have to see from the anterior horn cell up down to muscle. Okay. So from the anterior horn cell goes down to neuromuscular junction and muscle. Okay. So can it be spinal cord? Spinal cord because it has some kind of level lah sebab dia quadriplegia kan. Nerve root and plexus usually nerve root and plexopathy will have pain, radiculopathy, pain. And the plexus will involve multiple nerve. Okay, peripheral nerve. In peripheral nerve there are many types, mononuclear, polynuclear. So banyak type. Usually peripheral nerve dia akan involve that particular nerve sajalah. And if it involve multiple nerve, then maybe glove stocking distribution. So neuromuscular junction have fatigability. Okay, muscle, you can see the muscle atrophy or muscle bulk increase or decrease. Okay, so for this patient is actually having what kind of lesion? So we can see that this patient maybe have spinal cord. Tak boleh lah sebab dia upper motor neuron. Patient ni lower motor neuron. So the best is maybe peripheral nerve lah. Sebab dia tak ada fatigability, muscle okay, tak ada radiculopathy, and then peripheral nerve je lah. So this patient actually having GBS. Okay. Okay, last one. So 65 years old, chronic back pain, gradual weakness, upper limb and lower limb for 3 days. No numbness. So sensation okay, just power saja. Tone okay, reflex okay, Babinski downgoing. So lower motor neuron. And then you ask further, GP bagi furosemide, ada ankle edema. Noted potassium 1.3. So you do further workout for this patient, noted patient having type 1 RTA. So that's why patient have hypokalemia lah. So this slide I want to highlight, sometimes you cannot localize the lesion structurally, but you have to think also other systemic lesion or other metabolic causes that can present with CNS deficit. Okay, that's all. This is a few interactive things that you can look through. Especially the first one. The first one tu is actually the warm up yang I guna tadi lah. So there is dia ada banyak case. So you go through yang tu. After you do all the 32 cases, then you sure can do localization. The YouTube one is just for further landmark lah, further benda lah you nak baca. Okay, that's all.
Okay, so we just go through the questions. The first question was regarding the cerebral circulation statement, which is false. So it was the first, and the answer was cerebellum is supplied. It's not by the middle cerebral artery. It should be by your posterior cerebral arteries. So your next question was, which of the following statement is true? Occlusion to the anterior cerebral circulation may result. The answer was weakness of the contralateral part of the body. The next question, the third question was occlusion to your ACA will cause the following except it doesn't cause aphasia. It causes apraxia. Your aphasia is caused by your occlusion to your MCA. And then your fast mnemonic stands for all is correct except A is not. Your arm doesn't swing, your arm will go drifting. Okay, so next question. Question 5 is a 70-year-old man presents with an emergency room within 2.5 hours onset of left hemiplegia and global aphasia. His CT brain was shown, and would you give thrombolysis to the patient? I think the history was very brief, so the answer should be no. And then moved on, you got a further history where it's a known case of hypertension and having ischemic heart disease, and he was gardening as it happened. There was no witness of fit, and he didn't have any prior history of stroke or intracranial bleed. There was no history of surgery, no history of recent hospitalization or trauma. His medication has status, and his examination and blood investigations were unremarkable. So in this history part, they did not state yet the NIHSS score. So where the following, so the answer still be no. And then the next one is stated that the NIHSS score was 26, and your answer will also be no for thrombolysis. In view, it was a very high score. So in the CT brain, which territory was impacted? It's the right MCA. So we move on to the next question. Question 9, 34-year-old gentleman underlying epilepsy presented to emergency department with multiple episodes of beating, and on arrival, his vital signs were stated. So what's your first management? Would be all the following, except you do not put the patient in a supine position. He should be placed in the left lateral position. So all the following drugs can be given to the patient to avoid the fitting, except don't give scoline to a fitting patient. All right, so on the further history, patient defaulted his follow-up and treatment for 3 months, and he was on traditional medication. And they gave history of fitting 2 times at home and just before arrival to ED lah. There was no history of trauma, fever, or persistent vomiting, and there was no drug abuse. So which of the drugs can be given? Actually, both drugs can be given to the patient. It's just that the IV phenytoin 20 mg per kg should be run at 50 mg per minute, not 150. So there was the error there. So next, the patient completed the IV phenytoin infusion but was still fitting. So you can give the following drugs, except all the drugs can be given except your ketamine should be run at 5 mg per kg per hour, not 50 mg per kg per hour. So the following medication and chemical compounds match, except your midazolam, your compound is imidobenzodiazepine, and imidazole is actually for metronidazole. Okay, so next following question is the main actions of diazepam, except your diazepam doesn't cause a retrograde amnesia, it causes anterograde amnesia. This is actually in your Sasada, it's written in Sasada. I didn't write down the page, so you can just look through which page of Sasada. So the following side effects of side effects matches the drugs, except your answer should be sodium valproate doesn't cause gingival hyperplasia. The answer should be phenytoin that causes gingival hyperplasia. The others are right. And the last question, a 28-year-old man is brought to ED following a seizure at home. He was given midazolam by the paramedics and his seizure activity ceased. Which of the following neurotransmitter was predominantly inhibitory action within the CNS? It's your gamma aminobutyric acid. All right. So if any questions, you can just post it in the chat box there. Okay. Thank you.